We are having this hearing for the purpose of letting people around the state, various groups, various perspectives, explain to us, and in doing so explain to the larger audience the impact that the coronavirus has had on them and their various institutions. We've got a number of people here. It looks like we've got about 10 or 15 minutes per person, which is not much time, but we'll do the best we can with what we've got. I had hoped to have, as I've had previously, a video of Joe Burrow shooting free throw shots prior to the Peach Bowl, but I couldn't get that up and going. But we've been known to start off the committee meeting with that. I have attached to the agenda a letter to the editor that my dentist wrote. I went and picked up the paper one day, and there was this letter to the editor. I attached it to the agenda because I thought it did just an excellent job of setting forth in clear language, sentences, paragraphs, subject-verb agreements, all those wonderful things, just explaining the impact that the coronavirus and the way the virus is spread has on just what dentists do all day, every day, which is obviously a situation that's peculiar to dentists. So we have with us today Dr. Jimmy Hollingsworth for Newton, who's nice enough to come talk to us about the impact of the virus on his practice and to a larger extent on dentists around the state. Dr. Hollingsworth, just however you feel comfortable proceeding. We've got about 10 minutes, and sometimes members of the committee ask questions, so, you know, there's that.
I'll be glad to answer any questions.
And thank you very much for coming.
Well, thank you, and thank you for having me. And you can stop me at any time if you have a question, or I'll take those questions at the end. But first, I just want to thank you, Chairman Ryan, and the committee for your time and consideration. My name is Dr. Jimmy Hollingsworth, and I'm a practicing dentist in Newton, Mississippi, where I've practiced for almost 27 years, if I can make it to July the 12th. And I'm a past president of the Mississippi Dental Association and a delegate to the American Dental Association. Today I want to explain to you the landscape of dentistry during the COVID-19 crisis, how dentists have adapted to the new CDC and state regulations, and how we are impacted, and what we would like to request from you, the legislature. As one of the very first healthcare provider groups mandated to suspend elective procedures and to treat only emergency cases, many of our dental practices in Mississippi suffered a severe economic blow from the pandemic due to increased cost and decreased productivity. Even now, Mississippi dental offices are open, but at least 82% of them, and I think it's probably more than that, are seeing a lower patient volume, and I'll talk a little bit about why that is in a moment. Our dentists are committed to the standards set forth by the American Dental Association and the Mississippi Dental Association, and we closely mirror the CDC guidelines for best practices. Dental offices have always practiced safe procedures for our patients and for our staff and team members. One very unique factor for dental offices, though, is in the current situation are the aerosols that are produced by some of our equipment, the handpiece, commonly called the drill, and then as your hygienist uses an ultrasonic cleaner sometime to clean it. Those create aerosols, and we know that that's how COVID can be spread. These aerosols are the main factor in the extreme safety precautions that are necessary. There are many hoops that we had to jump through at increased cost in order to provide the proper and safe care for our patients. Dental offices have been affected in many ways during the pandemic. Dental offices were only seeing emergency patients most of March, all of April, and over into part of May. This did affect patient care. When dentists cannot see routine patients, their oral health conditions can deteriorate, and result in additional needed treatment. My office, which is like most typical general dentist office, our production in April was 10% as compared to the year before. Not down 10%, down 90%, only 10% of the April a year ago. And for the month of May, through this morning, I looked before I left, we're running at about 50% of our normal production. We are healthcare first as dentists, but dental offices are also revenue producer and job creators and contribute to numerous society sectors, from trade and manufacturing to real estate and utilities. According to a survey done by the American Dental Association, one dental office contributes an estimated $1.7 million annually to the economy. Now, that doesn't mean the dentist is making $1.7 million. That means that through his staff payroll, overhead, all the things that he buys or she buys throughout the year, and they put that much money back into the economy. Dentists are primarily small business owners. Most of the revenue generated in dental offices are not based on emergencies. Therefore, most of the dental clinics are forced to lay off most employees temporarily during the COVID crisis. Dental offices operate with high overhead of up to around 60% of production pre-COVID, when we're running at full capacity. With the decrease in productivity due to being able to see fewer patients daily, our overhead has increased significantly as a percentage of our production. A recent study shows that at least 17% of dental offices will close as a result of this pandemic. And dental offices, for the most part, are independently owned by the local dentist, unlike most physicians' offices that are owned by hospitals. The ADA recently performed a study on dental offices across the nation. Several important findings came from the survey that was published May the 18th. This is first, that dental offices are currently operating at 54% of their pre-COVID-19 numbers, and that's exactly what my numbers showed today when I ran my numbers in my office. So we were right at 50% of our time over last year. Approximately 58% of dental offices are fully paying their staff members, even though they may not be working at full capacity. Over half of our offices are still paying their staff members. Some of those dental offices are not working at full capacity, but had to hire their staff back in order to obtain their PPP loans. The partial closing of dental offices caused a big unemployment issue. Closure and or bankruptcies of small dental practices are likely as a result, and most of these practices are in small and rural areas. Access to care issues will grow even more without these local providers to treat their friends and neighbors. For the state, this means many more unemployed, substantially less tax revenues for the long and short term. This is a quote from the American Dental Association's economist. He says that for many reasons, COVID will accelerate the consolidation of dental practices. He's the chief economist and the vice president of the American Dental Association Health Policy Institute. COVID-19 is going to reduce the number of patients you can see in a day, so there's an additional margin squeeze, and the larger practices are better suited to weather the storm. This article also noted that an April survey of the Health Policy Institute of the American Dental Association found that 46% of dentists in private practice said they would consider closing, selling, or filing for bankruptcy if the current restrictions continue through August. Younger dentists that still have student loans from dental school, along with debt from opening or starting or buying a dental office, are really struggling during this pandemic because of decreased revenue and increased cost of PPE. Many dentists are unable to rehire all of their former employees due to decreased patient load and will not qualify for their PPP loan to be forgiven. The PPP loan is very specific in what qualifies, and an increased cost of PPE are not included. Now, I know that's a lot of PPP and PPEs, but the PPE does not qualify for the PPP loan forgiveness. Another factor that will affect many dentists is how those patients that are now unemployed may no longer have dental insurance, which will cause people to delay treatment and seek only palliative or emergency care. Patients will forego regular checkups and treatment, and this will cause more patients to seek relief in already crowded emergency rooms. The biggest obstacle to reopening dental offices was a lack of PPE, specifically the N95 mask and disposable gowns. Nationally, over 66% of dental offices have less than 14 days of N95 or KN95 masks, and 64.2% have less than 14 days of required disposable gowns. Mississippi dentists are being overlooked as healthcare providers when it comes to personal protection equipment. The per patient cost has risen from pre-COVID to from about 90 cents per patient to over about $24. During a patient visit, there will be at least 3 or more members of the staff that will interact with that patient. So all those people will have to have PPE. This raised PPE costs per patient significantly. Other dental issues regarding PPE is that with the requirement for PPE, we are unable to obtain it. An executive order from the State Department of Health specifically prohibits dentists from receiving any personal protection equipment from MEMA. No insurance reimbursement is available for PPE despite the cost per patient increase. And additional PPE regulations and social distance requirements that lower efficiency of clinical and time management result in decreased patient scheduling. In my own office, we're seeing about half the number of patients that I normally see in a day. That's just all we can do. And we have a pretty well-oiled machine at my office. And we're just about to get to about 50% of our normal daily people. Approximately 20% of dentists in Mississippi see Medicaid patients, and that ensures that our vulnerable population gets the care they need. Some relief for these dentists who accept Medicaid would be especially helpful, as we are sure Medicaid rolls are likely to increase due to the COVID-19 pandemic. Here's some specific asks that we have for your consideration. Dentists are only eligible for one of the funding tracks in the Small Business Relief Program the Mississippi Legislature created with the passage of Senate Bill 2772. Even then, dentists will be one of the last considerations after those who aren't eligible for PPP loans. Increased funding through the CARES Act would help tremendously. Legislative consideration for funding relief through grants of at least $2,000 or more and consideration for PPE allocation would go a long way to provide the help that dentists need to be able to continue to see our patients. A small prepaid Medicaid loan or assistance through increased FMAP funding would help dentists to see more patients and increase and improve access to care. Dentists and the dental teams are committed to providing quality oral health care. We always have, we always will. Dentists are one of, if not the hardest hit of healthcare providers and small businesses during this time, but we are committed to doing everything that we can to ensure the very best of patient care. Anything that could be done to help with these impacts of PPE, Medicaid, and additional funds to cover new costs would be greatly appreciated. I thank you for your time and will be open to any questions that you have at this time.
Could you tell me again what you said you were or were not eligible for under the legislation that we passed a couple of weeks ago?
Dentists were excluded from that $2,000 grant. And then if you were able to get the PPP loan, you'll be considered after those that were not. And not all dentists got the PPP loan.
And so when you say you'll be considered after those who are not, you're talking about the second part of the act, not the
Yes.
$2,000, but the reimbursement that can be more than that.
Correct.
Thank you. Do members have questions? Senator Witherspoon.
Thank you, Mr. Chairman. So how did you all are excluded from the 2,000? What,
We were just not listed. We were not in there.
that was for all small business?
My understanding is there was a list of codes that some entity has of what type of business you are, and there was a list of codes that were eligible, and you're not in that list of codes.
That is correct.
Thank you. Senator Parker.
Yeah, I've gotten some emails on the PPE issue and as it pertains to Medicaid. And I was just wondering if you have an idea, like for Medicaid, you know, one thought I had was if we had a temporary, like, service code, and I don't know, you know, like for certain, you know, things that you use, there might be a G code or there might be a special code that's just used for that. But if we assigned a special code for a limited amount of time to cover that extra PPE and we put a dollar amount to that, what dollar amount per patient encounter do you think would cover kind of the extra, you know, precautions you're having, the extra materials and things you're having to use on each Medicaid patient? Because that's the only one we could really make a change in.
Right, I understand that. And some of that would have to do a little bit with the procedure you were doing, but if you just wanted to do a flat overall, you know, I would, like I said, this study set up to $24 is the PPE cost, because it's not just the PPE for the dentist that goes in to see the patient. I wear an N95 mask, and I don't know if y'all have worn one of those, but it's like taking that and suctioning it to your face. And so I have that, a gown, I have a surgery cap on, boot covers, so all that, plus everybody in my office that will come in contact with that patient has to do that. And we're mandated by the State Board of Dental Examiners that we're only supposed to see the patient, one patient in that. So then we're transferring into new. So that's how you can get up to at least $20 or more per patient, because everybody in the office that comes in contact with that patient's having to change. And that's on top of gloves and all the other things that we're doing. So.
Right, because, you know, my thought would be that if you had a specific code that you could use for that encounter, you know, and you could bill it along with your standard ones, you could, you know, change that $1 amount, you know, and not have to go through the, you know, the whole process of changing what a visit code might be or that kind of thing. You could just, and you could do it for a temporary time or extended period. And have you had any conversations with Medicaid or Drew or anybody about that yet?
Well, since there's no code for that, you know, that would have to come through the legislature to say that code that you would pay for that. There's been a national discussion from the ADA, and I didn't say this, but I serve at the ADA on a council on dental benefits, and we work with insurance companies, we work with CMS, and have tried to get this pushed forward, and it's kind of been left to each state to decide what they want to do. But so many of our dental offices that take Medicaid are struggling already. And I've done a little study in that, and I spoke to you a few months ago about Medicaid, and our cost and what we receive for that treatment is almost even. So there's really no room to put another expense in there for PPE without the dentist losing money. And I did a analysis of a child that had come into my office as a Medicaid patient. I did their treatment plan. I did my fees of what my fee would normally be, and I have a rural office. I don't have high fees. And then I did that compared to what Medicaid would pay. It was about $1,800 roughly for my normal fee. Medicaid pays about $900 and something of that. Now, our overhead is over 50% of the $1,800, so that's about $900 of my overhead for that patient. Take that off the $900 that Medicaid was going to pay me, I make $2.40 on a treatment plan, which is going to be over about 4 visits for that patient. So we're down to about a penny a minute now for what that dentist is going to make. Not just me, but that'd be all dentists. And now we're going to put on there additional cost of per visit at least $25 for PPE times 4 visits, $100 on top of that. So many dentists are going to be reevaluating if they're going to be able to financially afford to take Medicaid because just of this one increased cost, because the margin was already so thin.
Mr. Chairman, just to kind of echo that point, I think it would be, it'd be interesting, at least for appropriations, to look at doing a potential temporary procedural code to cover towards PPE costs as one recommendation you might have from the discussion you have today. But I thank you for your time.
Yes,
Thank you, Dr. Hollingsworth. We appreciate your coming, and you have written materials that you're going to leave with.
We'll get you some if you
Get
want
us-
some. Okay?
Thank you very much.
Thank you.
Appreciate your time.
Thank you.
We also have with us today Marilyn Summerford, who's the Executive Director of Access Family Health Services in Smithville. For those of you who are not familiar with the geography, Smithville is in the very northeast portion of Monroe County, fairly close to the Alabama line. It's about 10 miles from Amory. It's about 15 miles from Fulton. It's really about 20 miles from Tupelo. But in between Smithville and Tupelo, there exists the Tennessee-Tombigbee Waterway. And unless you're flying, you've got to go to either Amory or Fulton to cross the river to get to Tupelo. So there is a relatively large rural area that's sort of distant from any health center. And right in the middle of that is Access Family Health Services at Smithville. So, Ms. Summerford, thank you very much for driving down. And I want to assure you and everyone else, when you hear this lightning, this is the safest place you could be. So
We believe
don't
you.
worry, you're better off here than anywhere else. But thank you for coming. Tell us a little bit about Access and how it works and the impact that this has had on you.
Well, thank you, Chairman Bryan and members of the committee. I appreciate this opportunity to share with you some of the work that community health centers in Mississippi have done in response to the COVID-19 pandemic. I am Executive Director of Access Family Health Services, a federally qualified health center that provides medical, dental, and behavioral health services at 15 sites, and 10 of those sites are school-based health clinics. We serve Chickasaw, Itawamba, Lee, Monroe, and Pontotoc counties primarily. We're a relatively small community health center. Last year we served 8,618 patients with 26,623 visits. I say we're small. If you look at the number of patients that were served by community health centers, some of you may not have community health centers in your immediate area, but health centers serve 307,000 patients at 228 delivery sites and provided about $124 million in uncompensated care, plus an additional about $13 million in managed care and bad debt write-offs. So if you look at the demographics of the patients typically served by community health centers, it's about 35% uninsured patients, about 30% Medicaid, about 12% Medicare, and then the remainder are private pay. I have spent my entire life in Mississippi, and after college I worked 16 years in a great community hospital and then returned to my hometown where I literally grew up on Main Street. My dad had the hardware store, and just right across the street was the doctor's office. When Dr. Tubb died in 1978, Smithville got their first community health center, their only community health center. And Dr. James Monroe from Pontotoc was a doctor fresh out of medical school. Fast forward that to 2011, when Smithville was ravaged by the EF5 tornado. Dr. Monroe and his staff at the health center were the first ones that were boots on the ground in the neighborhoods that saved lives of people that day. And if Access hadn't been a community health center, there's no doubt that we would not have a physician office even in Smithville at this time. But as small as it is, less than 1,000 residents now in Smithville, we have a health center there that draws patients from the surrounding area. It's our busiest clinic, even though we have a clinic in Tupelo. We have 2 doctors and a nurse practitioner, a very modern clinic that has an in-house pharmacy, x-ray, behavioral health, and we even have a farmer's market on the weekends where we give vouchers to our patients that are low income so they can use it on fresh vegetables. Our whole COVID experience seemed familiar and really similar to the tornado experience. We felt like we were just baptized with fire in the beginning because Dr. Monroe had been on a ski trip to Utah, and 4 days after he returned, he started having COVID symptoms. And 5 days later, it took a little longer than it does now to get the test results back. We found out that he tested positive. Well, fortunately, because he had traveled domestically, he wore full PPE when he was in the clinic, so we had no patients or none of his staff that tested positive. But it really was an eye-opening experience for us. It helped us understand the importance of testing, and we've continued to support the Mississippi State Department of Health testing efforts. We had already started we'd implemented procedures directing patients to call before they came to the clinic. We were also providing drive-through and curbside service and escorting patients from the car to the exam rooms after screening, and no waiting in the lobby. And we have also provided drive-through testing for all of our access clinics. We were fortunate that we had implemented a patient engagement and telehealth platform in 2018 that was part of a behavioral health grant. And that kind of came about after we had a patient that had pawned her TV just to get from her home to Tupelo for behavioral health services. So we were a little bit ahead of the curve with telehealth, and I want to say a huge thank you for the changes that were made with Medicaid that allowed us to be reimbursed as telehealth providers, because that actually has made a tremendous impact on our viability. We've had 1,129 visits via telehealth during this pandemic, so that's not shabby for a small organization, but the telehealth revenue did help offset some of our losses and has been wonderful for our patients that were afraid to come in the clinic. Of course, there were some issues related to broadband and cell phone minutes that were related to that, but we really ask you to consider extending that at least to the end of the year. Because we have school-based health clinics, we just deployed our staff to the medical clinics when the school closed, so there was no revenue from any of those school clinics, and we kept our school-based health clinic staff employed by sending flyers out with the meal pickups and the packet pickups at the schools, so that parents and teachers knew that if their children needed medical services or behavioral health services, they could access those with their school-based health staff through telehealth services. Many, including Governor Reeves, have mentioned that health centers receive grant funding to fight COVID-19. But the thing is that when health centers, when we receive grants, it's announced on the news. Everybody knows that we received those grants, how much we got. But the thing that people don't understand is that these are very specific grants. And the grants that we received were around testing, personal protective equipment, like Dr. Hollingworth said, very expensive, to expand telehealth, and even for transportation, because transportation is a required service for us as a community health center. So there's very strenuous requirements around that. And one of the things that we did was purchase a used vehicle to help deliver our medications to our patients from our in-house pharmacies. So right now, our focus has shifted somewhat, still doing the testing, but a lot of focus on addressing the acute and chronic diseases that have been ignored because people were afraid to come to the doctor and in many cases have stayed home eating unhealthy foods and not exercise. So they're not anxious to come back to the doctor and get their blood sugars checked and their blood pressure checked. We've really lost a significant amount of ground in addressing our clinical quality measures. We're behind on our wellness visits. And as a health center, we don't get funding based on how many patients we serve as far as if we add sites or we add patients, we don't get additional money for that. We have to we generate revenue like other private physicians' offices too. The grant just helps for those patients that are uninsured and have no, and aren't able to pay. Last year, but the way that we do get increases is if we increase our quality. Based on the HEDIS measures, that's the only way that we get increases. So last year we were recognized as a Silver Quality Award winner, which put us between 11 and 20% of the health centers in the country that qualify for that. So we've got a lot of ground to make up in that area. Another area that we're focusing on is getting students and teachers safely back in school because we work with the schools closely as school-based health providers. We're trying to determine who will need testing, how can we help the schools determine about the social distancing, the infection control, and there's not a lot of time to do that. But we health centers still need money to help offset the cost of those services, just like the dental practices. We have not been, as we've been testing and doing these other things, we have not been able to make up for those patients that we couldn't provide care for previously. Over my 24 years as a health center director, I've seen fewer and fewer grants come to Mississippi to open health centers. They go to states like California and Colorado and New York that have more population density. But we're caring for the poorest and the sickest people in the nation. And many of these communities like Mound Bayou and Liberty and Fayette, wouldn't have health care without community health centers because hospitals just strictly can't afford to go in a community that small. And another thing is it's important because the patients have a voice with a consumer board that's representative of the patients we serve. But the one statistic I think that's most important is that we serve 13% of Medicaid beneficiaries with only 0.63% of the total Medicaid budget. So if we fail, then the people that are sick get sicker and they end up in the hospital, emergency departments, and sometimes long-term care facilities if they have a stroke or other condition like that. So, one of the things with our 340B program, patients are able to have access to their medications to control their blood pressure and their diabetes, and that's really important for that. A recent study that I saw from some physicians from Emory looked at social determinants of health and correlated those most at risk for contracting COVID and for dying from it. And patients that are served by health centers are some of the most vulnerable. Many of them live in multi-generational housing or multi-family housing. Then they go to work in our poultry plants and they go to work in our long-term care facilities. So, if we're going to slow the spread and stop this second wave, hopefully before fall, then community health centers need to be viable. We need to continue to be in these communities where other people won't go to provide care for these vulnerable Mississippians, and we just ask that we be included in this response. Can I answer any questions for you?
Thank you. Questions? If not, thank you very much. We appreciate your driving down from Smithville, which is even a bit farther than Amory. but it's 3 hours, no matter what you do. Thank you. Is Ms. Threadgill here? Ms. Threadgill, I didn't recognize you. Won't you come up now? Billie Jean Threadgill is the president of the Friend of God Ministries in Amory, which is a small operation, but I'm going to ask her to explain what they do, and in particular, the difficulties they've had as a result of the coronavirus. And thank you, Ms. Threadgill.
Thank you for having me. Again, my name is Billie Jean Threadgill, and I want to thank you, Ron, for giving me this opportunity to speak in front of you today. I am the current president and director of Friend of God Ministries. We are a 12 to 18-month drug rehabilitation program for women here in Amory. Started in 2017 with
Excuse me, could you pull the microphone down?
Sure.
Thank
Can you hear me now? I'm sorry.
The acoustics in here are not good, but thank you.
Okay. So we currently house around 14 ladies in our program. We're able to house around 20. We have 3 different houses that we house them in. We have the ladies that are actually being rehabilitated. Then we have a transition house, and then we have an aftercare program for the ladies after that. And so COVID has dramatically impacted our ladies. Because we are a nonprofit 501c3, we do not fall under the traditional guidelines of we're non-traditional employees. So the way we raise funds is our ladies host yard sales. We do cleaning for various churches and different people in the community. We also feed various churches on Wednesdays afternoons before church, and that's how we raise our funds. And so when COVID come through, we had to actually stop any kind of fundraising that we had, because most of our money comes from fundraising and what the ladies can raise for themselves. So we have no way of funding, and so being a non-traditional employee, we don't fall under the guidelines for the PPP. So what this means for us is our expenses monthly is around $5,000. We had a little money saved up for the ladies, and we have currently just went through all the money that the ladies have earned and saved, so we no longer have any way of financing our nonprofit. So what that means for us is these ladies rely on this program to get clean and sober, and for us to teach them how to be productive members of society. And when we can no longer do that, then they are no longer able to learn and to grow and then to get out into the society after the program is ended and be able to learn how to raise money for themselves. So COVID has drastically impacted not only us as non-traditional employees, but their way of getting out into the community. We no longer are able to do community service. One of the things of our program is community service, and so if we can't have any communication with the outside world, then they're no longer able to do their 20 hours of community service. Most of our ladies come from MDOC. I would say about 90% are MDOC. So when MDOC stops sending us ladies, we no longer have any opportunity for them to actually be rehabilitated. It's a shame, because a lot of these ladies need us to, if they finish the program, then they can, a lot of them are off of parole after 18 months. So it's been very hard. for us. Do you have,
So basically, you have a program which is a residential program
yes,
for women with addiction problems,
correct,
most of them coming out of the Department of Corrections.
that's correct.
And your method of raising funds for this shoestring operation is to clean churches
Yes,
and cook Wednesday night meals for churches.
right,
And since the churches don't have people in there dirtying them up, and they're not eating on Wednesday night, your revenue's gone away, and you don't seem to fit into any of the categories anybody has for relief.
that is correct.
I think I understand that you have essentially isolated the women that you were serving and the people that are serving them.
That is correct, because a lot of our ladies are actually immunosuppressed. So we've had to actually isolate them from a lot of people. We do not have teachers currently coming. We've slowly started back teachers, but they still have to practice safe distances. So a lot of our teachers are actually volunteers. So they are not having any outside communication.
And basically, I mean, my understanding is so far, none of your people have been tested positive for COVID. So,
That's right.
so far, so good, but
Yes.
at great cost.
Yes, out of 14 ladies, nobody has tested positive. None of the staff. We have 3 staff members that stay with them, and we've actually been isolated also. So we've been very blessed that we have not had any COVID-19 cases.
Thank you. Does anyone have any questions? If Senator Witherspoon.
Thank you, Mr. Chair. You mentioned the program is drug rehabilitation. What kind of services are you all offering to the ladies? Counseling?
Yes, ma'am. We offer counseling. We have, we do the 12-step program. We also teach classes about self-care. And so a lot of these ladies coming out of addiction don't practice good self-care. So that is a very big proponent of that. We also offer child classes, child parenting classes. That way that, you know, a lot of them do not have their children. And so we have classes on parenting so that they have the opportunity to get their children back at the end of the 18 months.
Senator Pope.
Thank you, Mr. Chairman. Thank you for being here today. How old is your program?
Our program is 3 years old.
New. Do you have any idea what your success rate has been?
This is one of our ladies that was actually in the program. She graduated a year ago. She is now an employee with Friend of God. She decided to stay on. So we have a pretty good success rate. We have graduated. Yes, we've been, out of the 5 ladies that have graduated, all of them have been successful except one. So
That's a pretty good success rate.
it's a pretty good success rate.
And you can handle 20 ladies?
We currently house 14, but we can handle up to 20.
Thank you very much.
Thank you. And again, thank y'all so much for driving down. We appreciate
you.
it. Thank you again. We have 2 food pantries with 2 different experiences. We have Nancy Huang and Bill McDaniel from the Amory Food Pantry. And so Nancy, Bill, however y'all want to divvy things up, if you could just tell us the experiences that you've had at the food pantry in Amory and the experiences you feel like you're going to have in the future.
Thank you again, Senator Bryan, for reaching out and asking us to come and speak today to this committee. We are both with Amory Food Pantry. I'm the current director, and he is the assistant director. So I'll tell a little bit about the food pantry and our experience with COVID-19, and then if you have any questions, we'll be happy to answer those. The Amory Food Pantry was established in 1986 by a local group of citizens, and it was very first in a small garage next to the Presbyterian Church. They served once a month with a handful of volunteers, and this organization was founded by local people to help its own. And while we've moved to a larger building, we have more volunteers, we serve more often, the routine of helping and feeding those in need continues with the same basis to help our own in our community. Our mission is to minister to the emergency needs of the residents of North Monroe County by providing food, to promote awareness of human needs around us and to collect local and statewide resources for their relief, to strive for a fair distribution of available resources. We serve groceries each Tuesday morning to approximately 120 families who come from diverse backgrounds and circumstances. Some of them have been laid off from work or disabled, elderly clients who have inadequate pensions or face devastating medical expenses. Still others are of the working poor and cannot make ends meet on minimum wages or part-time work. But regardless of the need for assistance, they all cannot afford adequate food for their families, and they are reliant upon the community to help them. Our annual budget is about $94,000, and the vast majority, about 90% of this, is food expenses. We rely on grants, donations, and food drives to keep our shelves full. And of the 40-plus workers each week, all are volunteers. Mississippi Food Network, Mid-South Food Bank, United Way, local businesses, grocery stores, citizens, churches, banks, schools, and civic groups all donate their time and money to help us keep our doors open. All clients who are served food are screened for eligibility as they visit the pantry using poverty guidelines. In 2019, we assisted 15,000 individuals. That totals about 5,000 households with life's most basic necessity, food. We distributed approximately 147 tons of healthy staples, including beans, rice, cereal, oatmeal, bread, eggs, meat, crackers, peanut butter, fruit, and produce. There's a lot more I could say about our food pantry, but that's kind of in a nutshell how we operate. So how has COVID-19 affected the food pantry? I'm speaking on behalf of the Amory Food Pantry, but we talk with Aberdeen and Nettleton and several other across the north of the state, but I feel confident that I can speak on behalf of any food pantries that are in a rural area trying to help those in need. So like everybody else, when this hit the 1st of March, we made the different modifications so that we could still be open as the pandemic began. Instead of clients coming inside, we started a mobile-style pantry where they stay in their cars, drive through, and we put the food in the trunk. We have small groups that work each day to avoid being overcrowded on any one day, and we safely work with masks, gloves, cleaning supplies. So initially, during the first month of the virus, we saw about a 50% increase of families that came through, and this leveled off after a couple of weeks, and pretty much it's when the government assistance started. It's when stimulus checks went out, it's unemployment checks, there was an increase in food stamps. But what was alarming is there was a 40% increase in new families from January to May as opposed to 2019. We are certain some of this increase will remain, but we have no way of knowing, and so we have to plan accordingly. And that's really the question for us as far as COVID-19. It's not how is it affecting us right now, but it's how is it going to affect us in the future? What does that look like for us? As I said, we rely on local schools and churches for canned food drives. a large amount of food comes in at the end of the year. We don't know if we'll be in school, if school will start and end, if that's something that we'll feel comfortable asking the schools to do. Is it safe? So that's a big drop, we'll think, in help with food. In May, the United Postal Office does Stamp Out Hunger. Some of you may be familiar with. That was canceled, and that's one of our bigger food drives. Towards the end of the year giving, with corporations and individuals not having work and unemployment, our private donations may be down, contributions down. And lastly, this government assistance is going to end, and we'll be here for our community to pick up those pieces when they don't have the financial means to purchase food. I don't know if any of you in here have ever worked at a food pantry or a food bank. I don't know if you've ever gone to bed hungry or if you've wondered where your next meal is coming from, but it's real. It's down the road, it's in our neighborhoods, and we'll be here and need the funding and the money to help those most vulnerable in our society.
Thank you. Were you planning on Bill talking, or?
He's here for support and questions.
Well, I think having you talk, you've made the right choice, clearly. Yeah. Questions? Anyone? Senator Horn?
Nope. That'll work.
Thank you, Mr. Chairman. Ms. Wong, thank you for your service. So Mississippi Food Network is heavily involved in dispensing food all over the state for its local partners. Is that correct?
That's correct.
And there's a federal program when the schools closed and a lot of the fresh fruits and vegetables got redirected to the Food Network and other local entities. Are you all participating in that?
Yes, sir, we are, with the produce boxes.
What has been your experience in participating with that program?
We just got that information last week. We were just alerted about that last week. So we have not rolled that program out yet, but we're told it's 2 nice-sized boxes of produce that would be available to get. One problem, we have a small truck. We don't have an 18-wheeler that can just go to Jackson and pick up the food. Our small pantry truck only holds, we're not supposed to carry over 4,000 pounds of food. That sounds like a lot, but it's not. So when you fill the truck up, and we're meeting in Okolona, Mississippi in a parking lot, sometimes that's difficult, even just getting the food here. We have some people who have graciously once or twice volunteered that have a trucking company and have gone down there, to help us get food. But we are in the process of trying to figure that out. And we did just get that information last week, in fact, about the produce.
And you are, would it be accurate to say that you could do more if you had more resources to manage and have access to?
We most definitely could do more, yes, sir.
What's your annual operating budget?
About 94,000. And like I said, about 90% of that goes for food.
So you have you depend on a lot of volunteer help to operate
It's all
the program.
volunteer. There's no paid. It's all volunteer, yes, sir. Most people who have a full-time job and make it work on the side, yes, sir.
Thank you, Mr. Chairman.
Thank you.
Thank you. Again, thank you all both for coming out. We appreciate it. We have from Greenville, Ms. Pandora Redmond. Ms. Redmond, if you'd just come on up, and Ms. Redmond is the Executive Director of Hearty Helpings Food Pantry and Soup Kitchen in Greenville, and she's here to tell us the experience that her food pantry has had during this COVID crisis. So just come on up and make yourself at home. Thank you for coming.
Okay, thank you, Senator. And I want to first give honor to God for being here, because it's a blessing to be able to tell you the story. And it's not just a story, but it's a life experience. My name is Pandora Redmond from Greenville, Mississippi. I'm a registered nurse with over 30 years of healthcare experience. I initially began, I have a for-profit business, Professional Staffing Solutions. With that, I did nurse staffing. We started an adult daycare and also home care services. And I'm kind of giving you that to let you know how we began the food pantry. During those years of the staffing, going out to the homes, taking care of the seniors and disabled, we noticed that they did not have food. Most seniors have to decide whether they're going to pay their bills, make groceries, or medication. And most times, food was the last thing on the list. So my staff and I, I asked everybody to just donate a canned good or whatever they could, because, they were making minimum wages, but we still pitched in to help our seniors. And the demand got so great that it was too much for me to handle, just doing it out of my pocket, because we've been doing it for years. So I started a nonprofit organization, Visions, and that's the original name of the business. And it was established to teach people how to get jobs, provide food, assistance, the food pantry, and, other things, education. But the food pantry, it was the first thing to get started because it had the greater need. And once we got the food pantry going, it just really, it grew. And that was our primary service. Throughout the few years that we initially started, was actually 10 years ago. We started in 2010, and here it is 2020. Our first month, we were serving 50 families a month. That went on for a couple of years, and when I joined Mississippi Food Network, we began to get more food, but out of every 4 cases of food, I had to purchase one. So they have a system, and like I said, everything was out of pocket. Went on and being a partner of Mississippi Food Network, they volunteered us to become a part of Feeding America. And that's when the Walmarts, we started getting meats, because we would give food, but we wouldn't have meat for the families. And we started getting meats and dry goods, and it went on to grow. Last year, let me go back to 2017, I'm sorry. In 2017, the food pantry, we were involved in a fire. We had a good system going. We were serving up to 200 people a month at that time, and we were doing really well. A fire next door building caught on fire, and it caused us to have to close our building. So this is my husband. I'm sorry I didn't introduce him. My husband and I, we've been working, and we had to move the food pantry outside to serve the people. We served up under a tree for about 2 weeks, and also we have a soup kitchen, and in the soup kitchen we had to serve on the back of a truck. We had bagged meals that we would go out to the church and fix and bring for the community. But I'm kind of nervous, but I'm just gonna be who God made me to be. I'm just gonna tell you that it's, as far as the food pantry, it's not easy, because it's not easy, not in a physical sense, but still it wears and tears on your heart, because 1 out of 5 adults are hungry. And this is pre-COVID. 1 out of 4 children go hungry all the time. And when a child comes up to you and asks you, they see me on the street, when they see me, they always want something to eat. They're hungry. When a child comes up and tells you that, they couldn't sleep last night because they didn't have anything, and that kind of wears and tears on you. And we have been paying for food out of our pocket through my for-profit, and it's been tight. It really has. It's been a challenge. But my thing, I thank God for putting us in this place at this time, because during the fire we had to move, and we moved to a barbershop family. So we were distributing food outside, through a barbershop, the back door of a barbershop. But God was doing that because our numbers increased even more. we started giving out more food. The community started noticing because at first we had no support from the community. People started noticing and they would, donate something. Schools started running dry. And it's not till we recently moved to a larger building last year that the numbers really shot up. God put us in a place where we could be there for the people, because in the barbershop it was too small. Now we're in a 20,000-foot building, it's 4 stories. It's a warehouse. It used to be an old furniture company, and it is huge. And it's, God set it aside for a time such as this. Our community has stepped in. The Community Foundation has been wonderful because our numbers jumped from 300 in January. We served 399 families. From COVID-19 in March up until now, we have served over 5,000 families, and it's been just 75,000 pounds of food in less than 3 months, from March to last week. And the numbers are there. Our numbers have grown 10 times the amount they were before COVID-19. And, the food is coming in, but it's a challenge. I have had Community Foundation to volunteer to come to Jackson, pick up food. We are a member of Extra Table out of Hattiesburg. They allow us they get food and help us. I didn't have transportation to come all the way to Hattiesburg or Jackson, so the Community Foundation, they volunteered to go pick up the food and bring it back. When they brought it, we had lines of cars waiting to receive. And it's just a challenge, and the community is coming together, but people are so hungry, distressed. People have come to the pantry. They have never been to a place like that before, had to act, and their self-esteem is already low. They've lost their job, or or whatever might have happened. Some people have had some people have had the virus. People in the family have had the virus, and the kids have had to take over the household. They've come and asked for food. It's just been so many things going on. It has been a blessing to be there for the community. And like I said, we can't do it alone. We have people that have helped us, the United Way, the Community Foundation of Washington County. They have been just marvelous. We've had Extra Table, and just some of the people in the businesses in the community have stepped in. And I know it's a need. We need more funding because I think we were left out of a lot of the grants, nonprofits. We have to rent vehicles sometime when we do come to Jackson. We have to rent a U-Haul, and it takes about $200 to rent it, to pick up food, because what Extra Table was allowing us to do was pick up extra food. They would bring it to Greenville once a month, but if you wanted extra, you would have to go and get it. So we would rent a truck, a U-Haul, to pick it up, so every other week we were picking up food. We were receiving food from Mississippi Food Network. I thank God for you all listening, because I just can't express how much it is tremendous. It weighs on your heart, because I have had elderly people, and they are dear to my heart. Just so grateful for what they receive. Whether it's 2 items in a bag or 10, it's a blessing. Whatever we can do, they are always appreciative of it. We not only provide food, but we help pay light bills through Power to Care, our energy program. We offer other assistance that might be needed in the home. We send people out to cook and clean. Our soup kitchen serves about 100 people a day, Monday through Friday. So those numbers have increased from 30 a day to 100 a day. Most of them are seniors because the adult daycares have been closed. The community has come together. The city has helped, done food drive. It's just still not enough. But we just thank you all for taking time to listen. I hope I didn't, but I just want to let you all know it's a need, and the COVID has changed everything for life. People are still, regardless of what goes on, well, sick, people are still going to have to eat. And the Delta is one of the, food deserts, and it's real. And that is my presentation, but any questions?
Thank you. We appreciate it. Do members have questions? Senator Horn.
Thank you, Mr. Redmond, and likewise, we appreciate the work that you and your husband are doing for the community in Washington County. I asked you the same question I asked Ms. Wong. Are you participating in the program that was stood up a few weeks ago, where the U.S. Department of Agriculture is making food available to different food networks and community groups?
Yes, our first delivery will be tomorrow. We're expecting 2,500 boxes of food and milk.
Now, are you getting your packages from the Food Network or out of Hattiesburg or where?
It's a farmer. He's working with Mississippi Food Network, and they're going to deliver it to. He's going to deliver it to our site, because we are somewhat of a distribution site. By our facility being so large, other people that they're going to come and pick up from our site. Out of the 2,500, we're going to get about 800 of the boxes, and the rest will go to other organizations.
And how often will you receive those packages?
Now, what he told me, it would be on a weekly basis. We initially were supposed to have started last week, but I think they ran out of boxes to pack everything. So this will be our first time tomorrow, and after that, we should expect it on a weekly basis.
And the program, as I understand it, is scheduled to end in June. I'm sure you would agree that if the federal government, USDA, were to extend it, it would be a good thing.
It would be a blessing, because we hadn't received the first delivery yet, but it's a need. Even though we give out food, we give out every week to our clientele, sometimes people come back and they need more, because some people have 10 children, some might have 2, but it's still, every situation is different, but it's still a need.
One final question. The Delta is well known as a great agricultural mecca. A lot of rich land up there. Is anybody doing any community gardening that you're participating with?
I'm sorry, repeat that last part.
Community gardening. Are folks putting up gardens that you're benefiting from?
The farmer that we are partnering with, sometimes they have green things like that in season, but none of the other farmers, like the program, they are not, donate to the pantry. But we do have one farmer that has donated, and he has an open field where the clients can go out and pick their own greens or vegetables.
Okay. Thank you, Ms. Redmond. Thank you, Mr. Chairman.
Senator Polk.
Mr. Chairman, I hear one recurring theme from both of you, and it's not that you have a shortage of food, which we should expect, and you do, but what I'm hearing is you have a shortage of transportation. Both of you seem to need vehicles to haul the food in. Is that something that y'all all need?
As we have I think it's a 15-foot box truck, but it's not enough it won't make it with that type of weight. We can't travel to Jackson to pick up 12 or 16,000 pounds. That's usually 7 pallets, and we just don't have we have to.
So some assistance in transportation would help y'all feed people.
Yes.
Thank you.
That's one of the big ones.
Thank you. Ms. Redmond, we appreciate very much your coming down and
Okay, thank you. And I do want to say, I want to say one other thing. The organizations that assist us, if they are awarded, to help, because we can't do it all, and even, but we can't do it all. That's all I can say. But thank you all. Okay.
Yes, ma'am. And again, thank you for coming down. It really helps us to hear from those of you who are on the ground dealing with the real world. Thank you. The Mississippi Ambulance Association has 2 representatives who wish to talk to us about the peculiar problems that ambulances are having during all of this. And I'll let the 2 of you divvy up your time however you choose to.
Well, unlike my friend from over in Greenville, and she was happy to be up here talking to y'all. I think I drew the short end of the stick today. But I do represent the Mississippi Ambulance Alliance Association, and I am Jamie Pafford with Pafford Medical Services, as well as Julia Clark with AMR. And Mr. Chairman and members of the committee, we are very blessed to be in front of you as well today, and I'm just picking. But as we represent our members of the association, we want you to realize that our constituents, our association actually covers 80% of the state. COVID-19 is definitely taking its toll on our ambulance providers, but when it comes to COVID-19, your governed and regulated local EMS professionals have been and are the frontline responders, just like fire and police in your communities, but we are your healthcare first responders. We are made up of EMS professionals like paramedics and EMTs, emergency medical technicians, and we're a vital part of the communities in which we serve. You know, most people don't realize, but we answer every emergency call regardless of the patient's ability to pay the bill. And our ambulance providers are often the very first contact patients have with healthcare systems in their communities. And in some Mississippi counties, EMS is the only healthcare provider. We're very fortunate to have many healthcare clinics around the state, but there are some of our communities that do not have local hospitals, and the clinics work their business hours. Therefore, we serve as that healthcare safety net in those communities. And I like to think of EMS providers as being special, and I go to Washington, D.C. a good bit. I am the chairperson for the American Ambulance Association Government Affairs Committee, and my family has been in the ambulance business for over 53 years. And I love to tell people the story about EMS and that we're very special. It's the fact that we are ready to respond at a moment's notice, 24 hours a day, 7 days a week, 365 days a year. And when that call comes in, our medics will do what they can to help you in your time of need. But everyone here expects that ambulance when you request it at a moment's notice. And that's what we're here today, is to protect just that. As board members of the Mississippi Ambulance Alliance, Julia and I know that many of you here around the table have offered your time and counsel to our members during this pandemic, and for that we're very thankful. But today we are respectfully coming before you to provide recommendations how we feel that the coronavirus aid package given to the state established through the CARES Act could actually be appropriately allocated to assist both public, private, and hospital-based ground ambulance services throughout Mississippi. As you see, as the funding continues to come down from the feds, the ambulance providers continue to be left out, and we just continue to fall through the cracks. But at the same time, we are across the state facing financial hardships and maintaining our cost of readiness, as well as many other medical providers were forced to furlough their employees and shutter their doors and services due to the COVID crisis. Ambulance providers have still been required to maintain our level of readiness in all of our communities. And we're not able to reduce our services because of our contractual obligations we have in many of our communities. And so as you see, many of us experienced a reduction in transports because of the closures of many facilities, and just the fact that our call volume has decreased up to over 35% for many of our providers, and we have a higher refusal rate of those patients because honestly they don't want to catch the COVID. They have the fear. They don't want to go to the hospital. During that same period of time, we're watching people that we go and check out and treat in place at their homes just feel like I don't want to go to the hospital, and we encourage them to go to our facilities because we know that that is a safe place for them. We'll go back days later, and those patients are super critical, if not dead, when we get there. You know, as you can imagine, many people talked about the cost of readiness, the PPE, and the expanded utilization of PPE. Well, now as ambulance providers, we actually don PPE on almost all of our transports since any patient has the potential to be a COVID patient. And when you talk about the space that you're in and you're 6 foot, when you think about a patient being in the back of an ambulance, some of them, if they're so luxurious to have a 10 by 10 box, I mean, that's all the space that you have for sometimes many hours of transport. Our decontamination of our ambulances after a COVID transport, in addition to the special wraps that go in the ambulances, have increased our costs that are associated with this, as well as our administrative management of our employees that are quarantined because they've had a positive COVID test or they were in contact with a patient. So this is made for a lot of paperwork for our organizations across the state and across the nation, just keeping up with that, as well as all of the providers having their commitment to pay employees while they're quarantined and taking care of their families, well as the provision of overtime and hazard pay and emergency pay to make sure that we can keep ambulances on the street because, as I said before, we're mandated to do such. You know, many of you will say or think that these things should be covered by FEMA or PPP. The loans and the grants come down by the feds, but 80% of our providers are not eligible for direct FEMA funding, as well as many did not qualify for PPP loans due to their affiliations. I do want to give a shout out to the Colonel at NEMA. He's been very helpful and listened and lended his ear to our concerns that ambulance providers had across the state and what our needs were. But the fact is that most providers hustled their equipment. Just like the dentist said earlier today, it's very, very difficult to get. And when you think about the numbers of ambulance transports in your state and what you have to do to keep your employees protected and those boots on the ground from getting COVID and protecting them, the numbers really skyrocket of the needs that we have. But the reality is that emergency medical services, the counties may not have the ability to pay their subsidies to the ambulance companies due to the loss of their tax revenues, which I'm sure you guys will continue to hear about. And these subsidies are pretty much the lifeline for many of the ambulance companies. Due to hospital cancellations of elective procedures, many closures, and or reductions in their staffing, ambulance companies are being asked to transport patients further and further distances, making some cases many counties away, thereby straining our resources in our local community. This has been a very trying time for our paramedics out in the field. I don't think they signed up for what they've gotten today, but they have definitely stepped up to the plate and been taking care of business this entire time and putting their patients first. These costs and losses are experienced by all types of providers, no matter if they're urban or rural, public, private, for-profit, not-for-profit, hospital, volunteer. We all have these expenses. And ambulance services operate on an extremely thin financial margin. According to two of our GAO reports, ground ambulance service providers are, of course, reimbursed on average below cost per transport by the Medicare program. Well, in the state of Mississippi, Medicaid reimburses us 30% below what the Medicare ambulance rate is, which further intensifies our situation, along with not being paid for the first 25 miles that we transport a patient. Ambulance providers did not get the 20% increased rates like the hospitals did in the CARES Act that came down and that other healthcare providers were given by CMS. So if I transport a COVID patient or a COVID symptomatic patient, I don't get an additional bump in any type of reimbursement from the federal government or the state at this time. More and more often we were forgotten in the relief packages, and as of right now, we are less than 1% of the Medicare budget on a daily basis. But during this COVID crisis and the CARES Act, we have received less than 0.5% of the overall outgo to providers. As COVID has spread through Mississippi, the critical role of our ground ambulance services have become very clear, whether it's responding to our 911 emergency calls or caring for our patients in their homes when hospitals or other facilities cannot accept them, or transporting the patients who require isolation to or from those important healthcare appointments that they have. The paramedics and EMTs who are following those medical protocols designed by medical directors and approved by our state and local governments are experiencing the same shortages of supplies, medicines, personal protective equipment, and personnel that the hospitals are facing. And at the same time, we continue to serve a very large uninsured population, as you all well know. In addition, ground ambulance services are mandated and must also provide care under local and state law when we respond to a call. It's a little bit about what I talked about earlier. When you call an ambulance, we're going to come and we're going to take care of your needs. Unfortunately, we are not reimbursed to provide care unless we also transport the patient. And this is very important here. An ambulance provider is only paid when the wheels turn on the ambulance. And we can offer so much more to our community, so much more to our states. And this would also have the treatment in place, ability to go to our providers under medical protocols, and by the approval of the state, we believe we can save lives and save money. So we urge you to implement policies to help us immediately for the coverage and treatment of treatment in place, which will not only be life-saving, but offer your financial savings, as I spoke of. All these factors have pushed Mississippi Ground Ambulance Services to the breaking point, and major U.S. newspapers, I know you guys watch plenty of the news, report the toll in the pandemic is taking on ambulance services has been very specific in the last couple of weeks because they've actually had EMS week was last week, so we were pretty much on the front lines of all of those news reports. If you're not aware, we have actually lost a paramedic in the state of Mississippi. He worked for AMR, and he did succumb to COVID symptoms, and we are really lifting up in his family and hoping that we can possibly provide a public safety officer benefit for him as well as we work towards that, because it's very important. He put his life on the line just like everybody else. But just simply put, the costs of maintaining readiness for our 911 systems are increasing as ambulance service organizations expend our resources necessary to provide the needed facilities, equipment in our areas. Here in your state, you have the National Association of Emergency Medical Technicians, whose headquarters is here in Clinton, and they recently released last week as well a horrifying result, which they feel like that nearly 2/3 of EMS agencies are expected to be financially insolvent within 6 months. Ambulance providers live from just about Medicare check to Medicare check. Their margins are so thin, and we're very concerned about how the future goes. On ground ambulance services carrying an enormous burden and responsibility as part of this pandemic, but tragically we're often unnoticed and unrecognized for our frontline role, and thus Mississippi Ambulance Alliance and our board of directors, and on behalf of all Mississippi ambulance providers, ask that the state of Mississippi provide a direct payment to the ground ambulance services on a per vehicle basis that were registered here with the State Bureau, say by April the 1st. We believe that for public and private ambulance organizations, reimbursement per registered vehicle is the appropriate methodology, and that's based on the increased cost of maintaining our readiness that we must maintain in our communities, as well as in addition to the new costs related to the coronavirus. Lost revenues due to the cancellation of elective procedures and similar medical necessary non-emergency transports, as well as increased labor costs that we talked about with our workforce having to expand it. The American Ambulance Association has a national formula for this, so I didn't just pull it out of the air. There's actually a formula out there, and it has been used to arrive at that per vehicle cost for reimbursement that I mentioned earlier. This per ambulance amount is also the sum that Alabama, Arkansas, Missouri, many other states are using for requesting funds for ambulance services in those states because they realize that there is a shortcoming, and that's what we want you to do today, is to realize that there is a shortcoming. And based on the Mississippi Bureau of EMS records, there's about 600 plus ambulances, about 622 transporting ambulance units in the state, and we would like to ask that the state of Mississippi for an approximate amount of $26 million out of the Coronavirus Relief Fund to ensure that Mississippi Ambulance Services and their paramedics and EMTs have the resources that are needed to continue to respond to the COVID pandemic and the funding to maintain the short-term and long-term viability of our operations. This $26 million represents approximately 2% of the $1.25 billion that the state of Mississippi is receiving from the federal government. So from the end here, just to tell you that it doesn't matter if it's a traumatic injury that requires a trauma center, a stroke requiring the stroke center, or a heart attack looking for the STEMI center, to the 911 call we have a long transport with. All of these things, the very basis of the improved outcomes is early access to care and early advanced life support treatment, which the ambulance industry across the state provides. Much like we have a duty to act for the 911 calls here, you know, my call is to you right now. My 911 call is to you right now, is to realize the situation that your ambulance industry is in the state of Mississippi. I've notified you of our failures that we feel like our communities associated with the implications to those who need your services if we don't find some type of funding on go forward. But on behalf of all of our patients, communities, and healthcare networks, it's vital we receive these funds through this request for this financial relief. I do realize I'm not asking you to go to your current budget, but I'm asking you to please tap into those federal funds coming to the state and allow our ambulance industry here in the state to be able to live through this and continue to provide that vital service throughout our communities. I'd welcome any questions, and I'm sorry to be so
Members of the
long-winded.
committee have questions? Senator Horn?
Thank you, Mr. Chairman. And to Ms. Grisham, we really appreciate the work that you and Ms. Clark and your various organizations are doing on behalf of emergency transport. You make a very compelling argument. You know, people don't think about an ambulance until they need one. And folks think that they're, you know, healthy and vibrant and so forth. And you mentioned that 80% of the providers are not eligible for PPP or EIDL.
80% of our association, 80% of the state of Mississippi has private ambulance providers covering it. And I believe we have a document that'll be handed out that shows you a map of the state of Mississippi. Yes, ma'am. And how it's coded. And as a private provider, we cannot get direct funding for FEMA money. We have to go through NEMA and other methods, and that's not always a sure bet for a private provider because they don't allow private providers to submit that. And for the PPP funding, there are some companies that were able to receive the PPP funding, a lot of P's, funding, but many facilities were not able. One of our largest companies in the state has too many employees, and that's not a negative on their part. They're the frontline providers in this community, in many communities, I think 15 counties within the state, and they were not eligible for that funding, yet they are a frontline responder in this whole epidemic, and that should be looked at. And we're also working on that at a national level.
And you also mentioned that 2/3 of EMS providers will be in major financial trouble within the next 6 months in Mississippi. 6 weeks, rather.
And I believe that was a nationwide study. There are over 14,000 ambulance providers throughout the United States. And I think it's 70+% of those make less than 1,000 calls a year. And so you could see where the hardship's going to come in for many, many communities. I'm a provider in Tunica County, Mississippi, and I've already been basically informed by our board up there that I may be receiving a cut in my subsidy that I have, and I know many, many other counties across the state are going to have the same issue as we continue to go forward. And this is why I just really am trying to put that earmark on that money to make sure we can maintain those services in those communities.
Okay, so I'm wondering, you mentioned a $26 million request of the relief fund. And then you also, prior to that, mentioned that you'd like to see adjustments made to county subsidies to help counties that aren't bringing in the money to be able to subsidize these providers.
I won't speak for the counties. I didn't have that in my proposal, but I could see where counties could come to you down the road and say, we don't have the funding to provide our EMS system right now. And so that's a real fear we have. But I also do know by you giving that amount of money, the $43,000 a truck is what it comes to, is actually, I feel like the American Ambulance Association's number was $43,000 per unit, and that's how they came up with that figure, and that's where you come up with the 26 million. I'm sorry, I must have flew right over it. I talk too much anyway, but that's where that number came from. So if I know, I've told you I've been in the business, our family's been in the business for 53 years. I know what those numbers roll out like, and they're pretty accurate to say from the month of March through June, the losses that we have, the cost of readiness that we've provided all of those communities without those revenues coming in, but yet we were still in those communities ready to make that ambulance call. That is where those providers in 2 and 3 months, June, July, and August, are not going to have the revenues coming in the door to take care of what they've already done.
All right, and you also mentioned that the emergency medical transport was left out of the reimbursement increases that Congress made available to hospitals and other providers.
The 20%, yes, sir. There's an addition. We do not get any type of additional bump on behalf of a COVID patient. We just are transporting as normal. We're not afforded that benefit.
And finally, you said that you need more support for uninsured patients that you have to carry.
And there are several methods with that through CMS right now, that we have the ability, just as I think last week through the third tranche of money, we have the ability to file a claim with those COVID-specific patients. So we're hopeful to see funding come from that.
And a non-COVID related question, but at the beginning of the year, I'd heard conversations about the fact that many providers are running into problems for non-medical emergency transport. Issues come up where someone needs to be transported, but it's not to a hospital, it's to dialysis, or that other companies are coming in and scavenging in those territories. Can you talk a little bit about that?
Well, usually a dialysis patient is a red flag patient to many folks in our industry, and they're very difficult to be approved for transport. So many providers, I don't want to say stay away from them, they just make sure that they go through their checklist to make sure that patient is able to take that transportation. In this period of time, the federal government has issued an exception because of the isolation that has to take place to that patient and their family while they go to the healthcare clinic, the dialysis center. So with that being said, there are companies that are coming in and doing that specific work. That work won't be approved after this COVID is over, and usually those patients don't require ambulance transport, and that's what throws people for a loop.
And back to the 26 million, I would assume that you would agree that a shot in the arm of 26 million, or whatever the legislature can come up with from the relief fund, needs to come sooner rather than later.
Oh, absolutely. The fear is in June, July, and August, when we normally would have our normal revenues that keeps us with our cost of readiness, will not be there. And most providers that did receive their PPP or received a bump from Medicare, their first round, a tranche of payments, that's gone. That's short-lived. We were very, very appreciative of it, but to be quite frank, the Medicare check, the Medicare payment that I got was less than 3% of what I billed the entire year of like 2018 is how they came up with it. And because an ambulance service is a fee-for-service provider, and we don't do cost reporting. This is actually the year that ambulance services across the nation were supposed to do cost reporting. We do not have cost reports. Therefore, when they started divvying out the money, a lot of that was based on cost reports, and we don't have those. So we were really at the bottom of the barrel when they turned it upside down and shook it, and we fell through the cracks on this.
Thank you, Mr. Grisham. Thank you, Mr. Chairman.
Thank you. We appreciate your coming to explain your situation to us. Our final presenter, Senator Blackwell.
Thank you, Mr. Chairman. I just have a couple of questions. The numbers on this sheet, are they the number of visits or transportations that you guys made?
That population?
That's the population per company that's on there. So if you see
The population?
AMR, and there's like 800,000, that's how many citizens we serve, so our 15 counties.
So it's not how many transports you made?
Oh, no, sir. No,
Okay,
sir.
just people.
I'd like to say that we would really like for someone to be specific from the Department of Health to work with us as we work with you with numbers. I'm sure my numbers shocked you, but the fact is we really last minute had to come up with our numbers and our ask, and that's why we use the Federal American Ambulance Association's policy. And if we had someone assigned to us to make sure that we could get our numbers right, the number of ambulances right, the number of transports in the state right, those are all important things for you guys to see as we go forward. We'd love to produce that for y'all.
Thank you. You mentioned that basically you get paid if the wheels roll. So during this COVID crisis, do you have an idea of how many visits you've made and people refuse to make the trip?
Yes, sir. We do from an individual company standpoint of that 80%. Most of us have had over a 30% refusal rate, and even higher than that.
All right, and then this 26 million, is that, are you looking at to replace revenue?
No, sir. It's to continue to keep the cost of readiness of the ambulance services in Mississippi on the road. So in that 26 million came from $43,000 for 600 ambulance units in the state. And the reason you put it per truck is because it doesn't matter if I'm a one-truck town in Charleston, Mississippi, or if I'm in Tunica with 3 trucks or Clarksdale with 5 trucks. It matters the number of units you have in that community because that's what you're having to provide in that area. So that's why it's so unit-specific and not county-specific or number-specific.
I understand that, and that makes sense.
Sorry.
But from a readiness standpoint, are you talking about you talked about cleaning the vehicle? What goes into the readiness?
Readiness, ready to roll, ready 24/7, 365, ready to make that ambulance call, fully staffed, fully stocked, and in addition to PPE. I'm talking about being ready to operate. And that's the real fear here, is not being there and not able to do that in the future if we're not properly funded in the months to come.
It is our PPE. It is paying for quarantine employees that may have been exposed during the time. It may be someone that's under investigation. So we're having to pay salaries for people, even though they may not be on the unit at the time, and then they get back to work and we put them back on the unit. So that's part of our readiness. There's a nationwide shortage of paramedics, so we're doing everything we can to not lose any of our staff. And so there's the PPE, there's the decontamination, there's the employees, the billing, all those kind of things that go into that readiness cost. And then one thing I want to bring up too, we forgot about, was hurricane season. We want to be able to keep what staff we have. I'm from Gulfport, so definitely watching for the hurricanes. But that's a part of it too, is now saying, well, we've got another disaster that could be looking at us too. And so we want to be able to keep our units rolling and have those readiness costs there.
And then
The red and blue on your map, it shows what's private and what's public, and why that's so important is due to the FEMA funding, and that, you know, private services are not eligible for SAFER grants and the fire grants and the Stafford Act funding. That's why that map is there, and that's why you being able to put money into the kitty is so very important, because there are not any other methods for us to get this funding if we don't come to you. And all of my meetings that I've had in Washington, D.C. with different staffers and our delegation up there, one of their first questions is, have you talked to the state yet? Have you? And I actually have services in my family has services in 4 states. And all of those, our congressional leaders up there have asked us the same question. You know, they know what's coming down from the feds, and where are we missing things at, and we're quick to tell them that.
And last question, do any of you provide air ambulance services? And if so, how have they been impacted?
It's been very, very difficult, and our ambulance services across the state have seen a huge, sharp decline in the number of transports that they're making at this point in time, and that is so very critical to the fact that, especially in our rural Mississippi areas, for that long transport time to get down to the metropolitan areas and the better hospitals. The fact is that they are suffering just as well.
Thank you. Thank you, Mr. Chairman.
Thank you. And again, we appreciate your coming to visit with us. Our final presenter is Bobby Beebe from the Mississippi Healthcare Association. It's my understanding that Mr. Griffin has yielded his time to Mr. Beebe, who can help us with the issues the nursing homes are having. Thank you for coming.
Good afternoon. Thank you, members of the committee. We appreciate having a moment to discuss with you the nursing homes and how they're affected by COVID-19 and the CARES Act as it relates to our current funding and those situations. I have 1 or 2 items to just mention up front. I wanted to pass along that Troy Griffin is unable to attend today. He's caring for his ill mother, and we are going to step in and try and cover both sessions. I had an opportunity to speak with him yesterday, told him we'd be glad to do so. I also have with me today Mr. Tony Hamrick, which is the president of our association, the Mississippi Healthcare Association. So, knowing that time was an issue, we tried to keep this to around 10 minutes or so, and also have questions. On the little PowerPoint, if I could begin that The CARES Act provided some funding relief to the state of Mississippi. As of May 15th, approximately $21 million based upon Medicare data from the prior years. If you were a Medicaid facility, there had only been no dollars received as of May the 20th to those nursing homes. So the first round of CARES Act funding was based upon previous data of Medicare Part A and Part B services, and that was known as the first and second tranche that came through to the locations. Those were done electronically through a physical intermediary. So no one got the same dollars or the same amounts. It was all based upon your previous activities, whether you had a higher Medicare utilization in your nursing home or if you did not. At that point in time, the idea was to help supplement because there were less number of patients in the nursing homes due to the fact a Medicare individual generally has 100 days of utilization or benefit that is given to them after, say, a hip or knee surgery, a heart attack, a stroke, etc. The average length of stay for persons who are under that Medicare length of stay are around 30 to 36 days, as we find as an industry. So therefore, what you found is if you took a snapshot in late February, early March, you had a certain number of patients throughout the state, and as April and May have come along, we've seen a reduction in the number of persons living in the nursing homes because those individuals have recuperated and gone home, and as we all know, hospitals are running at a very low process now because basically no elective surgeries are available, and no one is in the hospital unless it's a dire emergency. So therefore, that flow has all been down to a trickle effect, and we're sort of catching all this on the back end, and we'll see as time goes along through the summer how this will continue to affect our business. However, on May the 22nd, a second relief fund was activated where all licensed nursing home facilities received approximately $50 million in the state of Mississippi. So, by way of information, there are 208, give or take, nursing homes in the state, and we're licensed for approximately 19,179 beds that are in service. The latest statistics that I have for you on the bottom of the page over the year 2016, that's the last state report that was published by the division. And at that point in time, there were 16,476 patients, or 86% occupied. What we're beginning to see now, as I mentioned a moment ago, the reduction in the number of folks that were under a Medicare stay and the reduction in the census in our homes, we've found another 10% reduction. So you can take this 86%, drop that down to about 75%, and that would be our snapshot today. COVID has required substantial outlays for PPE, testing, agency staff, pay for regular staff as we isolate and cohort residents and prevent staff from working across units and increase the cleaning and infection control procedures. If I could take just a brief second to describe some of those phrases to you. What we were asked to do by CMS is to cohort, which is if there is a positive COVID patient, then we are sectioning our buildings to have a positive section for those individuals to be treated separately than with those that are under isolation or precautionary services, and then those who are not positive. What that does is that takes and makes the way that you run your organization even more sensitive because you have to dedicate staff to each level of care to try and work through those as individuals become either infected or come off or graduate from the COVID procedures. CARES Act released 2 deposits of funds to the skilled nursing homes via the physical intermediaries. So those were electronically funded as of this time. As of this report, there's a second area that is a potential relief to the state Medicaid program because the federal increase in the FMAP was 6.2%. So if you can imagine currently, under the federal guidelines under Medicaid, for basically every dollar you have put in as a state dollar, there's $3 to match. You were basically at 75% prior to this additional COVID funding, which is another 6.2, so that has risen the dollars that are available in Medicaid for future needs. At this point, as we speak today, there's been no provider group that has received any of those additional funds. That's just there kind of sitting, okay? The FMAP in general is always based upon the amount of poverty a state has. Some states are 75%, some are less, some are as low as 60, some are as high as we are today. We'd be near 80. So I'd like to give you a little brief history on census as we saw it before and census as we see it now. From 2003 to the year 2016 in general, if you just took general terms, you would have had 19,000 available beds. In general, you would have had 16,800 or a little less population in the homes year over year over year. We've been fairly consistent from 03 to 16, and anecdotally, from what I can tell of all our contemporaries, through the year 2019. However, COVID is going to make a huge drop in what we do and what we see going forward. Some of the issues we face currently are a reduction in overall census due to the fact families have taken patients home, the temporary shutdown of elective procedures that will not return back to normal for months, no elective surgeries for hip or knee replacements, no back surgeries, no stents or any other things unless someone is truly in a true emergency state. And so therefore, we did some polling amongst our association and the independent association and found over 50 facilities. Providers are down an average of 10% as of May. I can tell you in our company that we manage and oversee, we're certainly down 11%. I know of others 13, some a little more, a little less. So I feel very comfortable in that number that we've just given you. One major concern is in rural areas, if the census falls too low, we may look at some closures due to the fact there's a very limited market to draw patients from. We're not unlike the history of the small rural hospitals of several years ago, where in fact, if you're tucked away in a little small town that's got 1,500 residents in it, and there used to be a community hospital, which we actually operate in some of those little small towns, that community hospital is on a string as it is, or they may be closed. So therefore, people have begun branching out to the regional centers, and it's going to be very difficult for us to find patients to come back in these little small rural areas. By way of note, if you take a look today, there are 81 counties serviced by a nursing home or multiple nursing homes. The only county not served is Issaquena at this point in time, which is the true definition of being very rural. They have a home that provides services to them in both Sharkey and Issaquena together in Rolling Fork. So otherwise, we're out there servicing and taking care of people who are all throughout the state, many small homes, small towns, 60 beds or more likely than not, and we are a local community provider, and we want to make sure that we can maintain that ability. Because let's face it, the folks that we deal with are in their late 80s, 90s, et cetera, and it is easier to get to see us 5 and 10 miles away rather than 45 and 50 miles away. Most of the little small rural hospitals now are only having emergency room, MRIs, or other diagnostic services. So therefore, it gets very difficult to maintain what we're trying to do. Going back to the thought of telling you about a small home versus a larger home in a larger city, we're required by licensure standards to have many key staff members, whether I have 40 patients, 60 patients, or 120 patients. That'd be administrators, director of nurses, social service activities, food service, and the consultants and the doctors that all go along that. So if you can imagine when you look at your cost array, if your cost array is to divide that out by 40 people, 60 people, or 100 people, it's going to affect that operation of those homes. So in these first federal dollars that have come through, I can give you examples of our company and sort of what we've seen talking to other folks. In that first round of stimulus money, there was about $3.6 million that came through the places that we manage. So that was in late April. However, if you take March and April, and all the overtime, the personal protective equipment, the other cost of what we see and do, pool services, et cetera, we spent over $2.2 million just in trying to cover COVID issues. 10% reduction in census also reduces the revenues by another $1.4 million. So if you take that 3.6, you subtract the 2.2, the 1.4, we're basically back at scratch as of the middle of May. This second tranche of money that we've pointed out to you that came to us through the CARES Act, I predict will also go nearly as fast because we're faced with the same issues of there are not many new people coming in the doors. We're having advanced testing procedures, which means we cohort more, we watch more, and we have additional services that have to be provided. And then as that lack of clientele comes through, that revenue is going to drop, and I predict this will see very fast results to be utilized, used, and therefore gone away. In that ongoing labor cost, if a location had a COVID outbreak, any positive staff member would be required to stay out of that home and not render care or services for 10 to 14 days, take a test and be shown as being negative before they could return to care for our residents. In doing so, that puts a great stress on the remaining staff, and it pushes up overtime rapidly. And other providers in the area compete from the same limited pool, same employees, to try and take care of their businesses just like we take care of our businesses. So our labor cost has gone up tremendously. Next, we have a supply cost, which I think was a common theme of individuals we listened to today. So which sector would be allocated supplies is the question of the day. There was a priority list that was scheduled, of which nursing homes were at one time Tier 3, so there were all other manners of providers being top tier, and we were a lower tier to receive PPE products, which are N95 masks, gowns, face shields, etc. CMS fortunately relaxed some rules to allow the reuse of N95 masks as there were no backup supplies, and they're still very hard to come by. Most vendors were forced to place skilled nursing facilities on an allocation order because there was a limited flow of items, thus making price hikes the story of the day. I can tell you from exact experience that price hikes are still the story of the day. Number one, if I can find it, I'm paying 4, 5, 10 times more than it was in the beginning. Also, it is on allocation. So therefore, in the past, if we received or we used to order 5 boxes of N95 masks, I go back to my source providers, that's still what I get. So it's a trickle effect, which forces you to then go out into the open market and try and find what else you can get, of which, just one quick example, I, along with other providers that we have dealt with, went together. We wired money in mid-March for N95 mask and alcohol gel, and we finally got it on May the 15th. That's a long gap to try and make. Still provide care for all those that we're entrusted with. So to find the bulk items, you don't get to do that based upon a credit report. They want the cash in the bank before they'll even talk to you about shipping it. Then it gets shipped to a single location, and I described to someone personally not too long ago, I was in a parking lot in Natchez, Mississippi, getting face shields and face masks, and I said, I feel like I'm watching Breaking Bad again. We're loading up our vehicles, trying to distribute product out to people so that we can take care of those that we were entrusted with. And I predict this is going to continue for months to come. You know, there are, as a limited venue, everybody's scrambling for that same amount of product, and all it has done is driven up the prices and scramble us to get to where we need to be. If I could talk about a couple of proactive measures that we at the association have put together and gone through. Since late March, MHCA has held weekly conference calls with the Mississippi Department of Health, along with the licensure division. On average, we have 200 to 240 plus persons participate on that call. So those are administrators and directors of nurses and people in the field working with the residents. It's a live discussion with persons such as Ms. Frances Fair, who is the Director of Health Services and Facilities Licensure, Ms. Melissa Parker, who is the Director of the Office of Licensure, Dr. Paul Byers, who's a state epidemiologist, And what we do in those time periods is go through where the state stands with the number of cases, what are the latest CMS guidelines, what is the Division of Licensure asking us to do, and then in the case of Dr. Byers, how they were going to roll out the testing, which is in the middle of being done via the Department of Health and the National Guard. I would like to say that we welcome that testing that will allow us the opportunity to try and better serve our residents, better serve our employees, and do our best to take care of those that we are entrusted with. So far, and I'll be happy to have Tony address this too, there's been about 11 homes that I work that have already been tested during the past week from Thursday through Saturday and Sunday this week. And all of those went wonderfully because it was extremely organized. The guard and everyone has the greatest of attitudes to try and help out. Everybody gets in there, they get it done. An hour and a half later, they're heading on to the next location. So I have to say, our state is doing something extremely fantastic against what you may see nationwide, and it is nice to tell one good story, I hope. Another item that we have found that has been unbelievably good for us at this point in time has been the quick advance of telemedicine. You know, around March the 13th, all nursing homes were required to stop visitation, to limit access to our buildings, and to try and thwart the COVID-19 from entering the facility. So even the physicians and the doctor's assistants, the nurse practitioners, all have embraced this as best as possible, and they are using telemed for us to be able to consult with during our daily operations. Now, obviously, if a person is very ill and takes a turn for the worse, they're going to go to the hospital and receive services. But every chance we have to not send a person out is a chance not to bring the COVID back in. And the telemedicine has been fantastic. And many, many physicians and nurse practitioners have embraced this. So part of what we're here today to do is to explain that while we've received funding from the CARES Act in 2 different levels at this point in time, knowing that those additional costs are there, the reduction in the actual patients that we serve, and the history that we're quickly seeing from mid-February through today, those dollars will evaporate and be used sometime here in the summer. And we would like to ask to reserve the right to come back and talk to you, determine if there are additional needs. So currently, in the spirit of being honest and forthcoming, we wanted you to know what we had received via the federal funds, the background on why the first was based upon Medicare utilization, the second round was based upon pure licensed beds, and the services required for all of those folks worked out to $2,500 a bed, give or take. And that all was done by a simple math formula and straight out to the facilities. As a lot of us got that on Friday this past week. And to let you know just a little bit of where we stand and what we're facing and what we're doing. I'm available for questions, and Tony would also be available if there may be something related to a day-to-day operational matter.
Members have questions? Senator Witherspoon.
Thank you, Mr. Chairman. How are you all coming along with the testing?
Well, in my opinion, I think that the state will be able to do this in a little over 2 weeks. I know there was the article in Monday's paper, and it talked about how a lot of places in the nation weren't meeting the goal. But anecdotally, from what we're seeing in our company, and I think what his group, we both operate throughout the state, that they're rolling mostly from South Mississippi forward up through Central Mississippi. So what you guys were Saturday, correct? Columbia, Mississippi. I know in our case, Collins, Mississippi, Macomb, et cetera. So they're rolling north. And I mean this in the spirit of how it should be. These folks are truly in there for the right reason. They're embracing what they're tasked to do. And I know in some of our little small towns, we'll have 40 or 50 cars lined up. So the portico, which is normally where everybody sits on the porch and visits, that's the station, and the employees are rolling through in that fashion, and the residents are being tested inside the facility. Everything is bagged, placed in the ice chest, taken out for the medical labs to process and return the data later to us.
So you would say you are about 90% completed?
Yeah, I would say that would be a little broad, but I'm not going to bet against them. A fantastic job.
Thank you. Anyone else? Mr. Beebe, thank you very much.
We appreciate the opportunity to come and speak to you today.
Appreciate y'all coming.
Thank you.
Before we leave, I have several quick things that I can get through in a hurry, I think. First of all, I want to thank the committee for staying here so long. I'm aware of the time, and I'm aware that we still have a quorum, which speaks well of the committee. Thank you. Secondly, speaking for myself, I got something out of every single presentation. And what we had today, I think, is a picture or perhaps a mosaic of what's going on across the state. And there's a lot of different things all happening at the same time. The only way I know to bring that about, bring it to our attention, is to have folks come and talk to us, and I think that was very productive. Thirdly, I'll just say I continue to ask myself over and over how it is that the arsenal of democracy cannot produce hospital gowns and face masks. I just don't understand. Finally, I do want to make the committee aware, if you're not already, that Larry Kramer died today. May not be familiar with his name. Larry Kramer was an activist in the pandemic of a previous generation, the AIDS crisis. He was a radical activist trying to raise attention about AIDS. Founded the Gay Men's Health Crisis in New York, which was a leading advocacy group. After a while, they expelled him from the membership because he was too difficult, whereupon he said they were all a bunch of sissies. He would organize, he then founded ACT UP, which would do things such as have individuals go lie out in front of the New York Stock Exchange to try to draw attention to the large number of people who are dying of AIDS. He had an exchange with Dr. Anthony Fauci, who at that time was the director of the National Institute of Allergy and Infectious Diseases. He wrote an open letter, which was published in the newspaper in San Francisco, calling Dr. Fauci a killer and an incompetent idiot. They got to know each other. Dr. Fauci was interviewed for the obituary, and he said that once you got past the rhetoric, you found Larry Kramer made a lot of sense, that he had a heart of gold. And an interesting life, and a representative from a previous pandemic, which has a lot of parallels with what we're seeing today. Larry Kramer wrote a play called The Normal Heart. In 2011, that was revived on Broadway, and I went to see this play in 2011. Out in front of the Broadway theater was Larry Kramer with flyers that he was handing out to the playgoers, complaining about the continued lack of attention being paid to AIDS. He died earlier today. From the obituary, I see there's no particular indication that he died of COVID. But an interesting person with interesting parallels to where we are now. Thank you all again. We'll meet again next week.